Welcome to Embryology and Fetal Development. Some definitions of what we're going to be talking about in this lecture for growth. So hyperplasia is going to be cell division, and there's a lot of that to begin with the initial division once the ovum is fertilized. But that is truly just division, quantitative growth. Hypertrophy is going to be cell growth where they're not dividing, but they are just getting larger. So hyperplasia is more of them. Hypertrophy is larger. And there's going to be more cell growth, the hypertrophy, in the second trimester and on, where the first trimester, particularly in the embryonic phase, it's more about hyperplasia. Differentiation is turning into different types of cells. So types of cells that come together and transform into different types for different organ systems. Organization is similar cells that are coordinating, becoming organized, and becoming an organ system of their own. The vast majority of these diagrams and illustrations come from COAD, so you can refer back to that to see the diagrams more up close. So a quick review of fertilization. So the deposition of sperm. Ejaculate has 200 to 300 million sperm in 3 mL of seminal fluid, so it's very concentrated, and that gets put into the female reproductive tract. Cervical mucus acts as a reservoir and also a nutritional source as it is transporting that sperm or helping facilitate that sperm moving up towards the egg. The oocyte does not propel itself, but it's propelled by the cilia in the fallopian tube and the peristalsis type movement of the tube itself as the sperm moves towards the egg, and the egg is propelled by the fallopian tube. The sperm releases hyaluronidase, which breaks down the corona radiata, allowing the sperm to penetrate and have access to that inner lining, the zona pellucida. And the zona pellucida has an extracellular matrix, and it is species specific, which allows for only same species fertilization. Acrosome reaction is going to be the release of proteins and enzymes, which allow further penetration of the sperm through the zona pellucida, which is actually called the enzymatic drill. So it kind of helps propel the sperm through as it's pushing through to the inner part of the oocyte. Once into the zona pellucida, it starts the zona cortical reaction, which is essentially a lockdown of the zona pellucida, which helps prevent polyspermy. There are several mechanisms at play in prevention of polyspermy, and there are more details in COAD, but this is one of them. And then we have the development and fusion of the male and female pronuclei, which results in the zygote. And the zygote is diploid to implantation. So here's a kind of a pictorial view of what we've been talking about. And these illustrations kind of are just demonstrating what we went through as the sperm enters into the oocyte. Once this happens, the fertilized egg moves down into through the fallopian tube into the uterus prior to implantation. So there, you can see in the graph on the side, there's kind of a view of each step and what's happening through each step. So the embryonic division is going from 2-cell to 4-cell to the morula, which is Latin for it's Latin for mulberry or berry. So just remember of like a raspberry type structure. And then it becomes the blastocyst with 2 distinct cell lines and then implantation. So the embryo stage is 2 to 8 completed weeks, and then it's the fetal stage from 9 weeks to birth. So as we were talking about before, that ciliated epithelium of the fallopian tube and the fluid that it produces moves the embryo through to the uterus. And that initial cell division that you're happening from the 2-cell to the 4-cell is synchronous, and each cell is about the same size, but then it becomes dysynchronous. Generally, it's the same size, though, even as the cell quantity increases. So it's not getting any bigger around or taking up as much space, but there are more cells in that same space. Once we get to the blastocyst stage, that's where it starts developing an inner cavity, where it's not able to get the nutrients from outside as well. And so now it's creating an inner nutrient source. And it also sheds the zona pellucida, which is called hatching. So there are two distinct cell lines in the blastocyst. The outer is the trophoblast, which becomes the placenta, chorion, and extraembryonic tissue. And then inner becomes the fetus, the amnion, and the umbilical cord. As the blastocyst moves into the uterus, the outer cells of the blastocyst will secrete enzymes that break down some of the endometrium, creating a depression. And then the uterus closes over the blastocyst and the pregnancy is established within the endometrium. Those trophoblast cells are given nutrients from the endometrium and they start to secrete HCG, and that stimulates the corpus luteum to produce steroid hormones. So there is a certain amount of HCG that is critical for survival of the blastocyst, but that secretion of HCG is also what can trigger a positive pregnancy test. For our timeline, just to kind of give you an overview, this time is based on conception rather than the last menstrual period. Pretty much everything else is from the last menstrual period, but because this is specific to the embryo and fetus, we're going to use the time from conception. There are times in here, though, where I will note, okay, this is 6 weeks since conception, but that's 8 weeks since the last menstrual period. But pretty much everything in here, if you're trying to explain this to a pregnant person, you need to be able to say, okay, 6 weeks since conception, they're doing this. So then, all right, when you're 8 weeks since your last period, to be able to explain some of these things. So day 1 or even day 0 or -1, sperm can be deposited and penetration of the oocyte. Sperm can live for a certain amount of time in the vagina as it moves up, so it could definitely be a negative day. Day 2, the pronuclei unite, we have a zygote, and day 2 to 3 is that cell division and cleavage, which happens about every 12 to 24 hours. There's a complete division of cells. Day 3 to 4, the morula enters the uterus. Day 4 to 5, it's a blastocyst, which is floating around in the uterus. Then around day 6, the trophoblast attaches to the endometrium. And then around day 7-ish, the syncytial trophoblast invades the stroma. And you'll get more of that, or have probably already gone through some of that with the placenta lecture, but that's just kind of how that coincides with what is happening with the embryo. So here are some diagrams of kind of that travel. I always like to include multiple views of looking at the same thing, just because sometimes one will click over the more so over the other. But you can see that path as the unfertilized egg starts, and then you see that cell division starting to happen, and then you see when it becomes a blastocyst, it's becoming more of a outer ring with some inner cavities, and then that will start to attach and implant into the endometrium. The picture in blue is a blastocyst at day 5. So I believe this was through IVF, so you can see that it's starting to have a little bit more of a ring-like appearance with that collection of cells towards the top, but then that open cavity in the middle. Second week after fertilization. So we've gone through day 1, the blastocyst has embedded itself into the endometrium. And so then there's a lot of changes that are happening with this. For more information about the trophoblast, I would refer to your placenta lecture. There's also a really good video attached to this week's module. I highly recommend watching it, sometimes 2 or 3 times. Repetition can be a really good thing as you understand what's happening at this stage. So when you look at the blastocyst, there's the bilaminar disc that's developing, and there's 2 layers with that, which is your epiblast and your hypoblast. And while that's happening, the trophoblast is developing into the cytotrophoblast and the syncytial trophoblast, which becomes, if you'll remember, more of that placental development. That blastocyst cavity actually remodels twice, and there is the primary yolk sac and then the secondary yolk sac. The secondary yolk sac is the one that we're seeing on ultrasound when we're looking at those early ultrasounds. So a lot of stuff happening. Third week after fertilization, this is where she might have had a missed period by this point, because this would be 5 weeks since her last menstrual period. So gastrulation is complete, and this is where the embryo goes from one layer to three, essentially folding around itself to create different structures. So we have the ectoderm, the mesoderm, and the endoderm. The notochord process forms, so that's your primitive pit, neural plate, and neural folds, and that is essentially, the notochord itself is essentially the pieces of the neural fold. Vasculature begins to develop. The primitive heart tube is forming, which is creating the basis for the cardiac structure. And then the caudal eminence and the somites. And caudal eminence is essentially the head structure. And then the somites are the little ridges that you're going to see in what looks like a tail appearance. And so that starts to form at about in the third week after fertilization. So this is that diagram of the gastrulation where you can see the three layers starting to form: ectoderm, mesoderm, and endoderm. And you can see the hypoblast and the epiblast are kind of the basis for those, and then it becomes the trilaminar disc. Neurulation, this is the three layers, so that trilaminar disc separating into different types, which will then form the organ systems. And these graphics are in your co-ed text. So the neural groove is completely pinched off into what will become the brain and the spinal cord. So this is that third week after fertilization, so 5-ish weeks by LMP. And this is the time period where you think about spina bifida, which is incomplete closure. Alpha fetoprotein leaks when the neural groove is not completely closed. So that's normal. There's a normal amount of AFP in the maternal bloodstream. What's not normal is if it continues to leak, so it's not fully closed, you will see a higher AFP in the maternal bloodstream after it should be closed. So if you think about the genetic side of it, you would be looking for elevated AFP later on after the neural groove has been completely closed. So like 17 to 18 weeks from the last menstrual period. So something to tuck away when you're looking at the genetics. All of these layers, these are the setup for organogenesis. So all of the organ systems are going to come from one of the three layers. Fourth week after fertilization, neurulation begins and is completed. 4 to 12-ish somites are prominent. So if you're looking at a picture of this, you could count so many and get an idea of where we're at developmentally. Lateral and longitudinal folding occurs. There's so much folding as these structures start to develop. Cardiac activity can typically be seen on ultrasound at week 6 from LMP, so approximately the 4th week after fertilization. The heart begins to beat or pump. This is an important thing to know about when you have someone who has some anxiety about an early pregnancy and wants to determine, is there a heartbeat? They will tell you, because you can find on Google, that there's a heartbeat at 6 weeks. And they will often request an ultrasound. You have to be real careful with that, because if you are looking to establish viability, you need to make sure that you're far enough to where that's actually going to be. Yes, it can start even in the 5th week from LMP, which would be the absolute earliest. But make sure if you are doing an ultrasound that you are far enough along that cardiac activity would be established if that's why you're looking. The other thing to keep in mind is that the heart beats irregularly initially, and sometimes it'll start and stop or be at a slower rate. So it wouldn't be alarming to see a rate of 75, although in our minds we're like, wait a minute, it's supposed to be 110 to 160. That's okay as that system is developing and maturing. That will also speed up. So as we get into like 11 weeks from LMP, which would be 8-9 weeks from conception, it can actually even be into the 160s, 70s, 180s. And then it kind of levels off usually by 10 weeks from conception into that normal range that we get to see. The ventricular septum moves, and so that takes this heart tube into a 2-chamber heart. And then some other changes that are happening, the hepatic plate starts to appear and the respiratory diverticulum appear. Crown rump length, which is typically how we're measuring an embryo, from the top of the head down to the bottom of the rump, because it this stage, the baby is going to be in more of a C shape, and that's about 4 to 6 millimeters. On this diagram, you can see some of that folding that's happening, and you can see that the somites are developing. So these are 2 views of the folding, and these are from your co-ed text. So you can definitely look at that to get an idea of more specifics on that. The 4th week continued. This is a busy week in utero. The pharyngeal arches begin to form, and that's going to form the basic craniofacial structures. So that's the beginning of your face, jaw, ear, neck. Eyes are going to be forming. Germ cells are migrating from the yolk sac. Buccopharyngeal membrane ruptures, which will become your mouth. Pancreatic bud and spleen. Urorectal septum begins to form, and that's what separates your urethra from the rectum. And then you start to see some upper and lower limb buds appearing. This is a diagram, or rather some pictures of approximately 4 weeks after fertilization. So these are embryos that are about 5 to 6 millimeters, so approximately 4 weeks after conception. The first embryo on the left, you can see it doesn't have limb buds yet, but there is a bulge where the heart is starting to develop. The second embryo, you can see the heart is that center bulge, and then behind it is some lung development that's happening. And then when you look up on the head structure, you can see those brachial clefts and arches for brain development. And you can also see a limb bud that's starting to form. 5th week after fertilization, this is definitely another busy week in utero. Crown rump length would be 7 to 9 millimeters. So general overview of what's happening when spinal nerves are sprouting, the heart valves are forming, lymphatics and coronary vessels are appearing, the stomach curves, the metanephros, which is the beginning of your kidneys, will start to develop. You can start to see those cerebral hemispheres as that brain develops, and then the genital tubercle appears. So you have the beginnings of sex organs forming. Genital tubercle is going to be the male or female phenotype based on the XX or XY chromosomes. So 5 weeks after fertilization, so you can see that the structures are becoming more defined or more prominent. Notice in the picture on the right, the yolk sac, which is now smaller than the embryo. In the beginnings, as it's developing, it's typically larger than the embryo, and now it's kind of reversed. Most of these images are from ectopic pregnancies, where the pregnancy was in the fallopian tube. So outside of that, there might be a slightly different structure, but focusing in on the embryo, it's really fun to see the changes even from week to week. When you're looking at this on ultrasound, these are some exceptionally good ultrasounds. These would definitely be transvaginal ultrasounds. So this is approximately 5 weeks or 7 weeks from the LMP. So I would expect to be able to see some cardiac activity. But yeah, you can definitely see that these are tiny and definitely different from the pictures that we have. 6th week after fertilization. So again, an overview of what's happening, kidneys, genital ridges, mammary ridges, pigment in the retina, so there's starting to be some eye color, finger rays are becoming distinct, nasolacrimal groove forms, cerebellum forms, melanocytes enter the epidermis, and the physiologic herniation of the gut. So the gut is really more on the outside at this point, so something to think about with like gastroschisis as that develops, but a lot of things happening and forming at this point. So you can see these pictures, crown rump length would be approximately 11 to 14 millimeters. At 6th week after fertilization, you have webbed hands. So there is some of that apoptosis or programmed cell death that happens to the cells between the fingers. So eventually they will not have such a webbed appearance. That pigment in the retina, you can see that starting, and the melanocytes, they do not become pigmented until exposed to light. So at this stage, you wouldn't be able to tell yet if those melanocytes are necessarily present. 7 weeks after fertilization, so we have 16 to 18 millimeters. Skeletal ossification begins, so this is where those bones are starting to ossify. Sertoli cells are differentiating in the testes. Elbows and toe rays appear, and the elbows is a really interesting thing that you can start to see on ultrasound, which is really fun. And that tells you, all right, we're probably about in the 9-week range if you can see that bend in the arm. Eyelids are forming, nipples, first hair follicles are appearing, urogenital membranes rupture, the trunk elongates and straightens. So baby becomes a little bit less of that C shape and more into that kind of human structure. This is about 16 to 18 millimeters. You can see elbows. There's a bend in the arm. The hemispheres of the brain are more visible, and the fingers become more visible as that apoptosis happens, and baby starts to have some facial structures. 8 weeks after fertilization. So we have full rotation of that primary intestinal loop as it moves into place. The hands and the feet bend and approach the midline, and we have purposeful limb movement, which is really fun to see on ultrasound, especially when you're doing an ultrasound for dating and viability, and you can show parents the little person on the ultrasound moving around. And we have a definitive superior vena cava and aortic arch. The vas deferens begins to form. The kidneys move up and actually touch the adrenals. And usually by the end of the 8th week after fertilization, that urine production starts, which will also be making up part of the amniotic fluid. So it's partially made up of fetal urine, and the urine production starts in this stage. So here are some pictures of what 8 weeks after fertilization looks like. You can see specifically on the center picture that extraembryonic column, which contains loops of small bowel. So again, thinking about gastroschisis and whether or not that would be present if that gut completely moves back within the abdominal cavity. So definitely it looks more like a human, and you can see that those fingers are more differentiated. They're not webbed anymore. So this is a summary of weeks 4 through 8, which is the embryonic stage. So we've gone from folding and that C-shape cylindrical embryo, and we've had the 3 germ layers differentiating into various tissue and organs, unquestionably human characteristics by the end of this, and this is absolutely the most critical period of fetal development. So this is a view of the critical stages in human prenatal development. So when you look at where the embryo or fetus is at the top, so weeks, and this is also measured from conception, and then below that is the red and the yellow about how sensitive or how vulnerable the embryo or fetus is to certain insults from various sources. You can tell in the beginning that it's a critical time for development, and then as you get further on in the pregnancy, there's less vulnerability to certain insults. You can see in the first 2 weeks, it's kind of all or nothing. It's either going to develop or it's not, where later on in the embryonic stage, you're going to see more of defects that baby could sustain, but still continue towards viability, towards term. So the red part is crucial for major defects, and you can see it's not spaced out evenly, but prenatal care often doesn't begin until 8 to 10 weeks, which is kind of a shift that's happened. So you can see by the time you get to 8 to 10 weeks, we've definitely missed a lot of the most vulnerable stage of prenatal development. So this is something to consider when you're doing preconception visits, because you may not be seeing a pregnant patient until 8, 9, 10 weeks. And so doing a lot of that teaching at preconception can be a great opportunity. Something else to consider when you're looking at this is that if you do find a defect, so let's say you're 20 weeks and you find a cardiac defect, you might want to consider what else is developing at that stage and what would have also been vulnerable to insult at that time. So just because it wasn't found doesn't mean that it didn't sustain some injury. So when we're looking at birth defects, the 3% statistic is what you would typically find at delivery. So baby is born, you're doing your newborn assessment, you're assessing the palate, and you realize that there's actually a cleft palate on this newborn. Later on, more defects will be found as some of the more subtle things are caught by pediatricians or family practice providers. And so by 2 years of age, that 3% statistic actually turns into 5%. And then by 5 years of age, it's actually 8% as some of those more subtle things develop and demonstrate themselves. But specifically for defects that are identified at birth. So when we break those down, about 10% is going to be chromosomal. About 10% is some sort of prenatal exposure, which we talked about in our last slide. 5% is single gene expression. 25% is multifactorial. And generally, 50% is going to be unknown, where we really don't actually know what caused the defect or insult. Spontaneous abortion or miscarriage. So 10 to 12% of these are clinically recognized, meaning what we've seen HCG levels rising or seen a gestational sac or something on ultrasound. But there's quite a bit more of this that is just not recognized or not diagnosed. Chromosomal abnormality is the most common reason for miscarriages, and the majority of those are in the first trimester. So the rates of miscarriage decrease with increasing gestational age. So each week of pregnancy is less likelihood of miscarriage. Terminology, something I want you to take away from this is that the term abortion is the end of a pregnancy, regardless of how that happens. So if it's a spontaneous abortion, which is without any outside influence, it just happens, or an induced or elective abortion, which is mediated by non-physical factors. It's something that is done. So abortion is the correct term for miscarriage. However, it can be construed as an induced abortion. So be aware of that, especially when you're charting, when you're talking to patients. Most people understand a miscarriage to be a spontaneous abortion, but they may not know that abortion doesn't always mean induced or elective. So something to keep in mind as you're talking to patients. That fetal period, 9 weeks to birth. So the embryonic period is the first 8 weeks. Organ formation. Overall growth is slow. We're talking about millimeters of difference from, the 2-3 weeks since fertilization to the 8 weeks. The fetal period is where that growth ramps up, and we have rapid growth with 18 to 24 weeks being the highest rate of growth. Growth does taper off at 37 to 38 weeks, but when we go back to those initial definitions, so we had hyperplasia versus hypertrophy. This is where you're seeing those two phases. Determinants of fetal size. So growth slows near term as reduced placental blood flow happens. And there's also other factors. So like substance abuse, tobacco is a significant factor in slowing fetal growth, maternal nutrition, things like gestational hypertension or chronic hypertension on medication, things that could slow growth. There are significant growth concerns when there are multiples, as essentially those babies are sharing space and resources. There's also genetic influences. So chromosome 11, IGF2 controls fetal size. What's interesting is that the paternal chromosome promotes growth and the maternal chromosome inhibits it. And I always remember it as the one who is going to give birth is probably less interested in having a giant baby. So a way to remember that. There is quite a bit in your readings about determinants of fetal size, so I would definitely hit up your readings. 16 weeks after fertilization, we're taking a jump, and this is a height of about 5.5 inches, a weight of about 6 ounces. We've got eyebrows, eyelashes, fine hair. This baby can grasp, it can kick, it can somersault. So we're looking on ultrasound, definitely larger and more defined. On the left, if I remember correctly, this is about a 16-week fetus this is their head circumference or head measurement. You can see that white part is that ossified bone. This is something when you're looking at it, you can identify exencephaly or anencephaly if you are not able to see complete white skull formation. And the picture on the right is a baby measuring, it looks like about 12 weeks and change. And then this is that crown rump measurement. So this is about the latest that you'll do crown rump measurement. Once you get into the second trimester, then you start doing like head circumference, abdominal circumference, femur length, and things like that. But this you can see is a really nice crown rump measurement. Viability. This is an ever-changing topic. This changes as technology changes. I think about viability when I was in nursing school, and it was usually around 28 weeks, where now we usually say about 22 weeks and about 500 grams or more. This is very resource dependent. Baby born at 24 weeks in a rural setting may not have the benefits of being born in a urban setting or a setting with more resources. So this can be very variable depending on where you practice. Speaking of variability, the fetal dimensions get really difficult to assess later on. When we were looking in the embryonic stage, a baby that measures this many millimeters is probably this many weeks, where as you get into the fetal stage, Then you have babies that are genetically more likely to be bigger or smaller based on parental stature and things like that. So it gets hard to determine fetal age based on just the dimensions. So eyelids is kind of when you're out in a setting where you're having to determine, do you start resuscitation or not? So whether or not the eyelids are sealed when a baby is born is kind of a rough estimate of whether or not you should start resuscitation. Term development, 37 weeks is considered term. 37 weeks is early term, but it is term. And there is a lot of development, though, that's happening between 37 weeks and 40, 41, sometimes 42 weeks, where this is a time when the clock starts ticking when you're the one who's pregnant. And sometimes our patients may need more encouragement or a boost for continued pregnancy. There's a lot of development that happens, specifically the brain development. The March of Dimes has some really good images of what a 35-week brain looks like versus a 37-week versus a 39-week. So there's a lot of development that happens. The lung development is refining blood sugar stability. So once the umbilical cord is cut, relying on fetal organs to manage blood sugar and temperature regulation. And then I always think about that suck, swallow, and breathe coordination. Babies that are born early term sometimes have a little bit harder time coordinating all three of those things. So feeding can be a little bit more of a challenge than a baby that's born a little bit closer to their due date. So things to consider as you're talking to a patient who's at the end of pregnancy. So this wraps up our embryology and fetal development. I do love this quote that was in the lectures when I started the program. If you don't believe in miracles, perhaps you've forgotten that you are one. This is an incredible stage of life, and I hope that this has given you a good overview as you prepare to go out and practice.